Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case of a myocardial infarction.
Okay.
Shall we start?
So this is a patient, 50-year-old male, came here with severe chest pain on the central chest. He's having palpitation, sweating. Last half an hour he is having chest pain. He never had chest pain in the past, but he is having dyslipidemia. His family history is positive. His father is having had myocardial infarction. Mother is having dyslipidemia. His elder brother had myocardial infarction. Now he has come with chest pain. So what can be done for this patient?
First, the initial 10-second assessment. As soon as the patient has come to our emergency, we ask if he is able to talk in a full sentence.
He is not able to talk.
He's not able to talk in full. So we started the primary survey.
Yes.
First thing is the airway. In the airway, we just check if there is any pooling of secretions or if there is any stridor.
There is no pooling of secretion, but he is having difficulty in breathing.
Difficulty in breathing.
Cough is there.
So next we come with the breathing B, in which we check the saturation. Saturation is 93% at room air.
Okay.
So we ask, can you please connect oxygen face mask of 5 liters?
So it is dropping now.
We connected oxygen through face mask.
It's 85 now.
85 and respiratory rate of 22 per minute.
22.
And we even auscultate.
So there are bilateral crepitations are there, basal crepitations are there.
So right now we increase, as the saturation is dropping, we further increase the oxygen to NRBM mask of.
How much you want to increase?
NRBM mask of 10 liters.
10 liters, please start. Okay.
Next we come to the circulation component.
Okay. BP is 179/89, pulse rate is 97, regular complex, narrow complex rhythm.
The BP is on the higher side as of now, and the patient is a known case of hypertension. As the patient is a known
he's a dyslipidemic patient.
He's just dyslipidemic, not a known case of hypertension.
Not a known. He has never recorded any high BP in the past.
And the patient is in distress, as in now breathing difficulty. So this can cause the increase in the hypertension as of now.
Okay.
We corrected the breathing. Right now, saturation became 97%.
Okay. Saturation has improved.
Next, coming to the disability wise, GCS.
GCS is full.
Full. GCS is full, and we check for the pupils bilateral.
Pupils are normal.
Pupils are normal. Next, coming to the exposure, temperature of the patient.
Temperature is slightly higher than normal.
Slightly higher than the normal. So we ask to give 1 gram PCM to.
Please give 1 gram paracetamol.
And we take in we ask 12 lead ECG in the circulation part.
Please take one 12 lead ECG for the patient.
And apart from that, we put a large IV bore cannula and take the blood samples. As the patient is having a chest pain, to rule out the myocardial infarction, we send for a point of care HS drop T.
You want to
cardiac
okay. So we'll take. We'll give the report in very soon.
Yes, sir. Right now we got the 12 lead ECG.
Okay. What is the 12 lead ECG shows?
12 lead ECG is showing anterior ST elevations in the anterior leads of V2, V3, V4.
V1, V2, V3,
V1,
V4,
V3, V4,
V5, there is ST elevation.
ST elevation.
Anything else you want to know?
If there any reciprocal?
There is no reciprocal changes at present in the ECG. There is only ST elevation.
So, considering the history, the patient developed chest pain in the last 30 minutes, and he's having an ST elevation MI.
Okay.
So, we can consider the patient is right now having myocardial infarction.
So, your tropi is high now. It has come.
So, right now the patient has having a higher BP of 160/90.
Okay.
And because the patient is in the pain, we would like to start with nitroglycerin of 10 mics per.
Can you start nitroglycerin?
10 mics per minute, we'll start with nitroglycerin. Apart from that, any active chest pain is present?
Yes.
Active chest pain, so we can give morphine of IV 2 mg stat.
Morphine 2 mg.
Morphine 2 mg and then NTG, and oxygen is connected.
Oxygen is already connected.
Yes. So right now we would like, as this patient has came within the 30 minutes, so we can contact as having the cardiologist for PTC, a primary room.
Call the cardiologist.
Yes, sir.
Call.
Calling from the emergency department, sir.
Yes.
We have a patient of 70-year-old male with known comorbidities of
Tell me fast.
known patient is having anterior lead ST elevation MI. Within 30 minutes, he had come to our hospital.
Okay, you thrombolysis. Go ahead with thrombolysis. I'm not available.
Okay, sir. So as per the cardiologist is not available, so we can start with thrombolysis, sir. In this case, we can select with an altiplase.
We select and give.
Yes, sir. Altiplase weight of the patient, sir.
Weight of the patient is 70 kg.
70 kg. As it's above 67 kg, altiplase we'll give first uh, 30, 35 mg as over 1 to 2 minutes, and then 50 mg over next 30 minutes and 30 mg over next 1 hour. For regarding the thrombolysis, we continue that along with that BP monitoring of every
Start
30 minutes.
altiplase as per his order. Started
altiplase, and the patient BP also is now within the controlled range because
BP
of
is 135, 82 now.
Yes, sir.
Saturation is maintained 91. Heart rate is 90.
Patient is stable, vitally right now is in the stable.
We'll see. We will wait. The rhythm is changing now.
Yes, rhythm is changing into absent P waves and wide QRS.
There is
complex.
absent P wave, wide QRS complex rate is around 71 beats per minute.
So right now I would like to check the central pulses if there.
Central pulse is available. It is good. High volume pulse.
Yes, sir.
Normal volume pulse.
Normal. So we can consider it to be an idioventricular rhythm.
Okay.
Right now, because of the clot, thrombolysis and reperfusion of the dead, infarcted ventricular tissue, patient might be developing the idioventricular rhythm as of now.
Okay.
As of now, nothing much to be done regarding the rhythm.
Anything else you want to start now? Any other treatment you want to start now? So what all things went wrong here?
I did not give loading dose.
Went wrong is you didn't start a pain reliever first. You gave morphine after that. Morphine was given without any antiemetic. That is another problem. So you have started NTG first, and you have not given metoprolol. His BP was high. He had chest pain. So that is the one drug missed. So you missed 3 important drugs during the process, and you never tried to keep the patient in propped up position. He is having left ventricular failure. You didn't ask for BNP. We don't know whether he is in a cardiac failure or not. You have not asked for any echo. You have not asked for any chest X-ray. We missed so many diagnoses, but fortunately, patient survived because of your treatment. But what is happening now?
Now the patient went into VT ventricular.
So what to do now?
Right now, first we check the central pulses.
Pulse is not there.
Pulse is not there, so now we can start with ahead with the CPR.
Start CPR.
That is to CPR with AMBU.
AMBU is there.
Apart from that, right now after 2 minutes of the CPR, we reassess. If the patient is in VT, we can connect defib and give first shock of 200 joules.
You can give. You have to give.
Yes. We charge it to 200 joules, and then all clear and shock it. And continuous.
No, the rhythm. Continue CPR.
Continuing CPR.
Is there any problem in the rhythm now?
Yes, sir. Torse.
What is it?
Torse
is T points.
Polyventricular, polymorphic weight. Yeah. So right now we can give an injection MgSO4 of 2 grams.
Ask your next assistant to give. Let her continue the CPR.
Yeah. Another person can give injection MgSO4 2 grams.
And so that is given.
Yes, sir. And after 2 minutes, again rhythm is reassessed. The patient is still in polymorphic VT. Still the patient is in polymorphic VT. So we can give the second shock of 200 joules. All clear. Continue CPR. Again, after 2 minutes of the CPR, reassessing the cardiac monitor, we can see that the patient is right now having what is it? Asystole. Patient is having asystole. So we can continue CPR and continue every 3 to 5 minutes injection adrenaline can be given. The next 2 minutes we'll continue the CPR and after 2 minutes again we'll reassess. By this time, because we are not achieving the spontaneous circulation, we can try for advanced airway and we can intubate the patient.
Okay, please intubate.
Intubate the patient.
Advanced airway is in place.
Advanced airway is in place, and now as advanced airway is in place, we can do every 6 seconds we can ventilate, and every compressions can be continuously given. After again 2 minutes, again we reassess the central pulse.
Central pulse is now it is available. It is coming back.
Central pulse is available, and the patient is having a narrow complex tachycardia of 120 beats per minute.
Okay.
So we can consider that return of spontaneous circulation.
Okay.
And the BP is the lower end of 90/60.
What we do?
We consider giving right now fluids as the first.
Fluids. Give fluids.
Give fluids.
He's telling to
200 ml bolus of fluid.
Okay. Anything else you want to give?
Now post return of circulation, we need to, if the patient is conscious oriented.
Patient is not conscious, he is sedated.
It's sedated. So we have to maintain the targeted temperature of 34 to 37 degrees Celsius.
Okay.
And we need to even maintain CO2 between 35 to 45, saturation of above 95%, and glucose of 80 to 120, 150, 80 to 150.
Okay. Okay, so what all things we had? This patient had a myocardial infarction.
Yes.
He had anterior myocardial infarction, and you had done some mistakes. It is not gross mistake, but we could not prop up the patient. We didn't give Lasix. We didn't give antiemetic along with morphine. And what else was there? You started NTG first itself before giving beta blocker. Okay. Now, when a patient come with myocardial infarction to emergency room, how do you manage? Now you analyze your mistakes and stepwise you tell what.
Initially, we make the primary. After making the primary diagnosis, we need to give the loading dose of ecosprin 300 ml.
Suppose the patient had already taken, already on ecosprin, can we give loading dose?
Yes.
Still we have to give. Even if the patient is on aspirin, clopidogrel, still we have to give, because we don't know whether the patient has taken the tablet or not. So we have to load the patient again, aspirin 300 milligram and
clopidogrel of 300 milligram, then atorvastatin of 80 mg.
80 milligrams should be started. Then
after that, first we have to do the pain management.
Pain management is the most important thing in hospital, because that is the fifth vital sign in a patient. So pain is most important sign in any patient. If the patient is having pain, you have to manage that first. Why should we manage the pain in myocardial infarction?
Patient, so that his tachycardia and the hypertension.
So whenever you have pain, you have more anxiety, more tachycardia, all these things can occur. Then patient's condition can deteriorate very fast because of the adrenaline surge in the body. Patient deteriorate very fast. So you have to relieve the pain first. You can give morphine. Along with morphine, what else you can give?
We can give vasodilator like nitroglycerin.
Along with morphine, what is the drug required?
Antiemetic.
Metoclopramide. Antiemetic has to be given along with morphine. What are the contraindications for morphine that you should know before giving?
Inferior wall MI.
So inferior wall MI, we have to be very careful in morphine, and hypotension, bradycardia, all these things we cannot give morphine. Inferior wall MI, why we are worried about morphine?
Because inferior wall MI usual complication would be heart failure, and we will not.
Okay, they can have cardiac failure, they can have bradycardia, they can have hypotension because of the blood supply to the SA node is the same as inferior wall. So morphine has been given. You have given metoclopramide along with that. You already given aspirin, clopidogrel, statin. Then what is the next treatment?
Next treatment, depending upon the vitals, like if
Vital was
there's
good in this patient, as in this
hypertension was
BP was normal or slightly higher?
slightly higher, so we can start with NTG to reduce the work.
Again, you are making a mistake. NTG should be given, but which is the best drug to relieve the problem in myocardial infarction? NTG can be
Sublingual ISO.
You don't think about metoprolol?
Yes,
NTG you have already started,
yes,
but you have not given metoprolol. That is one of the most important drug in myocardial infarction. Why it is very important in myocardial infarction?
it reduces the contractility of the heart, workload of the heart.
It reduces the workload. It reduces the heart rate, so that it reduces the workload. It reduces the oxygen demand. The consumption of oxygen will be reduced. So metoprolol has to be given. Suppose you give 1 IV metoprolol. What is the dose of metoprolol? What is the dose? 5 milligram. 5 milligram first dose. If it is not working, then second dose can be given. Then the third dose also can be given. Only contraindication is metoprolol induced anaphylaxis or past history of hypersensitivity. Or if the patient is having asthmatic episode, then you have to be very careful in giving metoprolol. Okay. So after that, once the patient is given metoprolol, then even then the pain is not relieving, you can start NTG. So will the NTG reduce the pain in myocardial infarction? Will it reduce or not?
Yes, sir.
Yes or no? Huh? It cannot be, theoretically, it cannot reduce the pain. That is a problem. But whereas in Prinzmetal's angina, suppose you have same finding, ECG finding, you have started NTG, ECGs are reversing, and if the patient is telling that I am relieved from the pain, then you have to think about Prinzmetal's angina. What is Prinzmetal's angina?
It is the
Vasospastic angina. So when you give NTG, that spasm will be relieved and pain will be relieved. Whereas in myocardial infarction, it's a complete block of the coronary, so that will not be normally relieved by NTG. Okay, that's why a beta blocker has got more role in myocardial infarction than NTG. But whereas in other types of acute coronary syndrome, NTG has got a better role. So you have started NTG, you have not given metoprolol. Then what else you have to give?
oxygen.
Oxygen should be given in which type of patient? Which subsettings you can give oxygen? Eh? Only if there is a desaturation, you are supposed to give oxygen. Suppose the patient's oxygen is full, normal, 90, like first initially it was 95%. Can you give oxygen?
Not required.
Is it dangerous or not dangerous?
Then
It is dangerous. It is not good for myocardial tissue. More oxygen is also not good. So we don't give unnecessarily. We should not give. And if the saturation is dropping down, anyway you have to give. And you have to keep the patient in propped up position. Why we have to keep the patient in propped up position? Especially this patient. What was the problem? You are auscultated and you found out that there are bilateral crepitation. That is sign of pulmonary edema. And you have not asked for BNP. BNP, with clinical examination, you can make out there is pulmonary edema. That itself is enough. But if you ask for a BNP and if that is also elevated, then that adds to your diagnosis. Okay. So what other things you have to give in that condition? Suppose the patient is having
diuretics.
So you should have given diuretics. When you see there is pulmonary edema in a myocardial infarction, if the BP is good, if we are allowed to give Lasix, you have to give Lasix. So you are not given Lasix in this patient. That may produce problem in the patient afterwards. So Lasix has to be given. Then what other things you have to give?
We can start on BiPAP if he's having breathing difficulty.
Okay, if patient is having still breathing difficulty, you can better go for NIV ventilation. That will be useful initial stages. Then what else? What else was done? What is missing in this? That is very important. Any tablets are missing? Sorbitrate is NTG only. That you have started NTG. There is no point in giving sorbitrate. You have missed one tablet. What is that? Aspirin is given. Statins are given. One more tablet. Huh? AC inhibitors. Yes. What is the role of AC inhibitor in myocardial infarction? That has to be given within 24 hours of hospital admission. Whether you take the patient for thrombolysis or what is it, coronary angiogram, PTCA or CAPG, whatever it is. So you have to give AC inhibitors or IRBs like that. What is the role of AC or ARB?
Remodeling of the heart
It
tissue.
prevents ventricular remodeling. What is ventricular remodeling?
Because of the
Infarcted tissue will be like that area will die. Okay, then that area will be thinned out. Then that area will be aneurysm. Like they'll form an aneurysm. To prevent that, you have to give AC inhibitors or ARBs in the initial within 24 hours. You have to start. What are the contraindications for AC or ARB?
If the renal
Creatinine is
creatinine is
elevated.
elevated, or
One
if
more
there
is
is a solitary kidney,
single
single
kidney.
kidney.
Then bilateral renal artery stenosis. One more physiological condition. Physiological condition, which happens only in female patient. Pregnancy also you should not give. So these are the basic things you have to give in a patient. Now this patient is settled. You have intubated. You can extubate after sometimes. You have thrombolized. Now how do you follow up this patient? You want to take an ECG again?
Yes.
Hmm?
Post thrombolysis.
Post thrombolysis, you have seen that radioventricular rhythm. Radioventricular rhythm is good or bad?
Post thrombolysis.
Post thrombolysis, if you are seeing a slow BT, that is a sign of reperfusion. You call it as reperfusion rhythm. Okay, reperfusion is actually good, but sometimes it can go like what you have seen. It goes to the complicated rhythm like VT or Torsades D point is. What is the difference between VT and Torsades D point is? Difference between VT in a rhythm strip and Torsades D point is.
Alternating
Okay,
ventricle.
VT is only either positive or negative.
negative.
Wide complex rhythm, either positive or negative. Torsades point is
Alternating
twisting
along
around
axis.
the axis. So some complex will be positive, some will be negative. What is the treatment difference?
Magnesium sulfate.
Torsades D point is it's magnesium sulfate. Other one, VT?
Other one is shock initial
Shock.
2 times, and next we can start give
Okay.
amiodarone.
So what is the difference between SVT and VT shock?
SVT would be
SVT you have seen yesterday. We gave only very small volume of shock, small dose of shock. So here how much you were
200.
200. So high dose we have given. Now how do you follow up this patient? This patient is admitted with myocardial infarction. You have probably thrombolized the patient. It is not as good as your CAG, but you have thrombolized the patient. How do you follow up this patient? Can we discharge the patient today?
No.
When will you discharge?
Once we can get a coronary angiogram.
Is it a must to have a coronary angiogram after every myocardial infarction?
If,
This patient want to go tomorrow. Can you discharge the patient?
no, the patient right now has to be stable.
You want to go? This patient want to go tomorrow. We have thrombolized the patient. Can we send him back?
No, we need to look out for the risk of bleeding.
There is no bleeding. You have thrombolized the patient.
Within 24 hours to 48 hours, it can develop.
He want to go. After extubation, he want to go. What medicine you advise? Whether you like it or not, you want to go. What you do? Clinical scenarios are like that. They will not stay here for a year. This one. Your
dual
advice.
antiplatelets.
So you tell me what treatment you will advise for the patient.
Dual antiplatelets and a regular dose of statins.
You tell me the dose. Exact
Ecosprin
dose.
75 mg, clopidogrel.
Ecosprin 75 mg you want to give. Is it correct or not? Is it correct or not? 75 mg is correct or not? Primary prevention is 75 mg is okay. Secondary prevention is after myocardial infarction. You have to give minimum 150 milligrams. So 150 milligram is the dose of aspirin. You want to give ecosprin. What is the difference between aspirin and ecosprin? Both are same.
No, entry coated.
Ecosprin is entry coated. Okay, aspirin is normal aspirin is not entry coated. What is the basic difference?
Gastritis.
Can you give an entry coated sublingually? So that is the difference. Okay. Gastric problem is long-term entry coated drugs are good for stomach. But when you have a myocardial infarction, nowadays we are not getting aspirin. Plain aspirin, dispirin is not available. So you have to give a entry coated aspirin now. It's, directly you cannot put it in a sublingual route. You have to crush it and give. Then only it will be absorbed. That is the most important thing in ecosprin. So ecosprin 150 milligram. Then
Clopidogrel.
150. Clopidogrel 150 or 75. Okay, can be given. Then
Atorvastatin of 40 mg.
atorvastatin of
40 mg.
atorvastatin of 80 milligram.
80.
You have to give 80 milligram initially. Then only you can reduce. So aspirin, clopidogrel, atorvastatin.
Then patient had signs of failure, like pulmonary edema for
Yes.
the diuretics.
What diuretic you want to give?
Furosemide on
You
tablet
give triple
for-
drug therapy for the left ventricular failure now. He is having left ventricular
Left
failure post myocardial infarction. You tell me 3 drugs which can prevent my further failure.
ACE
AC inhibitors or IRBs. Then second one,
diuretic.
diuretic. Which diuretic you want to give?
Furosemide
Furosemide with
with spinal
spironolactone. Furosemide is for fluid removal.
Fluid
Spironolactone is for
potassium sparing.
potassium sparing, and that also got an action in the heart that also prevents this remodeling. Okay, then third one,
beta.
beta blocker. Okay, beta 3. These 3 drugs has to be given for this patient. Anything else? He is having a sedentary life. He's a smoker. How do you advise for this patient? He'll ask whether I can do exercise tomorrow onwards. What is your advice? Huh? Tomorrow onwards, he can walk for 30 minutes. What is the advice you give? Somebody is having myocardial infarction, he'll ask you whether I can go for a walk tomorrow onwards. I have seen in the internet that walking 30 minutes is good for heart. Taking 30 ml peg is good for heart. Huh? Can you advise all these things? You have to advise, no? These are real situations. Can he walk for half an hour tomorrow onwards? This is called as graded exercise. You only advise graded exercise. So tomorrow you may be walking for 5 minutes. After 1 month only, you'll be reaching that 30 minutes brisk walking. Okay. So graded exercise only should be advised for the patient. Smoking? Can he smoke?
No.
He has to stop smoking.
Change the lifestyle habits.
Okay. Food habits.
Food habits.
You want to take every day 2 biryanis in the afternoon. Is it advisable?
No, sir.
Why it is not advisable? Let him take.
High cholesterol.
Huh?
Dyslipidemia.
If you take more food, what will happen to the coronary circulation? So sometimes even heavy food itself can induce ischemic events. Okay, but more than that, cholesterol containing food has to be reduced. Okay, whatever it may be. So it has to be reduced. You have to take a small frequent diets. That is advised in a patient with cardiac failure. That can be advised. Anything else? When will you reassess this patient? What reassessment can be done in the cardiology OPD?
We can get a echo and
so you have to do an echo. You have to see what is the ejection fraction. Any regional wall motion abnormalities are there or not. You have to find out any other complication. So what are the complications of myocardial infarction?
We can have any tear in the aneurysm, dissection.
Okay, dissection or something else. Left ventricular aneurysm. Okay, then what are the complications of myocardial infarction? Arrhythmias are most important. Immediate complications are arrhythmias. Yes. Okay, then left ventricular failure like this. Okay, left ventricular aneurysms can occur. Then how do you diagnose left ventricular aneurysm in ECG? Can you diagnose it by ECG? Echo you can easily diagnose. But when will you suspect that? If there is a persistent ST elevation even after 4 or 5 weeks, then you have to think about left ventricular, possibly the patient is developing an aneurysm. Then you can ask for a repeat echo. So you have to take repeated ECG after that. Then
angiogram to see which vessels are blocked if you want to do.
So since it was not done initially, we can do an angiogram now. Okay. Can we do an TMT for this patient?
No.
The patient don't want to do angiogram. That is also another scenario. Many patients, they don't want to do anything. Okay. Can we do a TMT after 1 month?
No. Huh? Right now the heart is.
If the patient is able to walk for 30 minutes brisk walking, then you can electively taken up this patient for TMT, provided that you have all facilities for acute management. So that can be done, but ideal situation is you have to take this patient for angiogram, angioplasty, or if there is multi-vessel disease, you have to take the patient for CABG. Okay. So now, can we discharge this patient now? Is it okay? So you are given all advice, but you have done some basic mistakes that should not happen in any patient. Okay? Thank you. So you understood now how to manage myocardial infarction. How do you manage? Now you have to tell. You have seen this. How do you manage it?